କିଛି ମଝିରେ ନଷ୍ଟ ହେଇନି? କିଛି ନଷ୍ଟ ହେଇଥିଲା ମଝିରେ? ବାନ୍ତି ହଉଛି?
If you can take it forward, yeah.
ଏଜ୍ କେତେ? ମଝିରେ ନଷ୍ଟ ହେଇନି?
So, good evening, everyone. I, Nitesh Srivastava, welcome all delegates and faculty members on behalf of Corona Remedies Limited in association with ECO webinar series. So, now I would like to welcome Satabdi ma'am to proceed further with this webinar. Over to you, ma'am.
Nitesh, very good evening to all of you from here in Siliguri. We welcome you all to this 14th episode of the ECO webinar series. This is a brainchild of Dr. Kalyan Barmade sir. It's what we do is enhancing care for healthy outcomes is our motto. So today the webinar will be focused on infertility. We have a talk and we have a interesting panel discussion in the webinar. To begin with, we would like to evoke the blessings of Lord and let's proceed with the lamp lighting. Nitesh.
रिपोर्ट देखिए तापर डिसाइड करिए आजिकल सकाल देखिए सकाल 9टा 10टा ভিতরে এমনি কেবে হয়নি বেলা
As we have taken the the Lord, let's begin with the program. The program director for this webinar series is Dr. Kalyan Barmade sir, who has just finished a very successful tenure as the IAGE president. He also has been the past chairperson of the Public Awareness Committee and has many appreciations to his credit. So over to you, Kalyan sir. Let us start the webinar. I would like you to introduce the webinar, sir.
For thank you, Dr. Shatabdi, for this introduction. Now we are here for ECO series of webinar, which is designed for OBGYN practitioner and not only IVF and endoscopic surgeons. This webinar
mute all.
Hello.
Kalyan, good evening. Please mute all because disturbances will be there.
Can somebody mute others? So ECO webinar series is for the gynecologists to learn day-to-day procedures, surgeries, and day-to-day OBGYN conditions. We are here with 14th webinar series of ECO, and I'm really thankful to Dr. Patnaik sir, Dr. Mahapatra sir, and Bhagyalakshmi madam for coming for this webinar and blessing us for this series. We are going to cover few important topics in infertility. The first is optimizing results of IUI by Dr. Sujata Kar madam. And then a ART bill is coming up, which is revolutionize the practice in IVF and infertility. So we are going to have a panel discussion where all eminent East Zone members will be talking with me about the new law of ART and how to tackle the common conditions of ART law. I thank all the dignitaries and chief guests for coming for this webinar. Thank you so much. Dr. Satabdi, can I have CV?
Yes, sir. Yes, sir. Nitesh, आगे कर दो.
Yes, yes.
Honors के CVs दे दो. हाँ. Yes.
So we have our chief guest, Dr. H.P. Patnaik sir, who was a vice president of FOXY 2009, Secretary General of Society of Vaginal Surgeons. And we have seen, and we have grown up seeing his vaginal surgeries since 25 years. He was the president of Association of Obstetrics and Gynecologists of Odisha 2015-16, governing council member of ICOG 2010-12, national corresponding editor of Foxy Journal 2012-22, 10 years, and chairperson of Geriatric Gynec Committee of Foxy 2004 to 2008. He is the ex-special secretary of Health and Family Welfare of Odisha State and ex-director of Health Services and director of Public Health of Odisha. So we welcome HP Patnaik sir to give blessings about this webinar. Welcome, sir.
Thank you, Kalyan, for those kind words. Actually, जब बच्चे बड़े होते हैं, I still really think you as a very kid in front of me and a very small child. And I feel very happy when Kalyan, you are growing up and up. I really feel very happy. God bless you. You are
Thank you,
risen
sir.
higher and you have more miles to cover, more milestones to achieve, where sky is the limit. And regarding this eco webinar, I don't know what is eco wisdom webinar or the meaning of eco, I don't understand. But this is definitely creating an eco all over the country. And the thing is that today we'll be discussing about infertility and assisted reproductive technique. With me are my brother and sister, Professor Janmejaya Mahapatra and Professor Bhagyalakshmi Naik. And the first speaker, again from Orissa, Dr. Sujata Kar, the Vice President and the incoming President of ISR. And I really feel happy, Kalyan, bringing all of us together in one fold and taking this to a great academic front. I wish you all the best, and I hope you will do more and more such informative academic webinars for the benefit of all gynecologists of Foxy and in country in general. Thank you so much.
Thank
Kalyan.
you, Patnaik sir. It is enhancing care for healthy outcomes for OBGYN. So where it is not only for IVF consultants, not only for endoscopies, but it's for day-to-day gynecology problems. So I welcome you for this webinar. And now Dr. Satabdi will introduce the guest of honor.
Yes, it's my privilege to introduce our guest of honors. We have Dr. Janmejaya Mahapatra sir with us.
Hello.
Sir is the consultant in Department of Obs and Gynae at the AH Postgraduate Institute of Cancer at Cuttack. He has been the past vice president of Foxy. Sir also has been the treasurer of AGOI and the treasurer of AICOG 2018 and also has been the chairperson of the clinical research committee, has been an examiner as well as the vice dean for the IMA College of General Practitioners. Welcome, sir. We would like to have your blessings for the webinar.
Thank you, Dr. Satabdi, for your kind introduction. Good evening, everybody. Respected convener and chairperson of Public Awareness Committee, Dr. Monica, and National Coordinator of Public Awareness Committee, Foxy, Dr. Satabdi. Chief guest of this webinar, Dr. H.P. Patnaik, Vice President Foxy, and guest of honor, Dr. Bhagyalakshmi Naik, Vice President-elect Foxy, chairpersons of the webinar, Dr. Bharati Mishra, Dr. Sujata, Dr. Lopamudra, and speaker, Dr. Sujata Kar, panel moderator, Dr. Kalyan, and expert, Dr. Andrapalan, all the panelists, teachers, seniors, my dear friends, and today's academic partner, Corona Remedy. It gives me immense pleasure to be the guest of honor of this webinar. First of all, I am congratulating the organizing team of Eco West Zone webinar series, that is enhancing care for healthy outcomes focused webinars for obstetricians and gynecologists. I think today's talk on optimizing IUI results to be presented by our great orator and speaker, Dr. Sujata Kar, and panel on ART law, moderated by Dr. Kalyan, will benefit our members in their day-to-day practice. I again welcome you all to this very important and informative webinar, where we will learn a lot from this webinar, which will help us to change our practice and ultimately translate to good clinical practice. Again, thanks to Dr. Monica, Dr. Kalyan, and Dr. Satabdi for inviting me to this webinar. Thank you all. Long live Foxy.
Thank you so much, Janmejaya sir, for joining us. We will now, we have with us Dr. Professor Bhagyalakshmi Nayak, ma'am. Ma'am is the HOD of the Department of Gynecologic Oncology at Cuttack. She has been the chairperson of the Oncology Committee. She is the governing council member of ICOG and the current vice president of FOXY, and also has been the assistant editor and honorary secretary of AGOI and assistant editor of the Indian Journal of Gynae Oncology. She's very passionate about her work in oncology. We welcome you, ma'am. We would like to have some words of blessings from you.
Yes, thank you so much. Thank you, Shatabdi, for having me here. But the first disclaimer is I'm no more the HOD. So this is an old CV that you have collected somewhere. Actually, Janmejaya sir is now the HOD. So that's
My apologies, ma'am. My apologies.
yeah, so we both work together, but sir is now the HOD. Yeah, so thank you so much, Dr. Kalyan, Dr. Shatabdi, and Dr. Monica for having me here. And I think it's so important to know these day-to-day little things. And I don't know, sir, H.P. Patnaik sir and Janmejaya sir have told so much about all of you. I think all of you are working so actively in FOXY. I think it all echoes. That's the meaning of echo, I feel. And Janmejaya sir has also explained what it really is. And it's nice to see Sujata Kar madam, Dr. Bharti madam are seniors and stalwarts. So it's always a pleasure listening to Sujata Kar madam. So looking forward to the scientific program. And I think ART, this bill is so important because most of us would never know about all these things related to law and regulations. We only are very good, passionate workers. We just go on doing work with all goodwill for the patient, but we never know when we will be actually looped into some problems. So it's so important for all of us to know. I think, thank you again, Kalyan. And Kalyan was actually a co-chairperson with me when I was the oncology committee chairperson in FOXY. So thank you so much. My regards to Hara sir and Janmejaya sir and all of you. And welcome our East Zone team to this ECO meeting. And please carry forward. I will be there throughout the meeting. Thank you so much.
Thank you so much, ma'am. Thank you so much. And I promise to collect your current CV.
Yes, that's also my fault. I didn't check. There was a CV in the group, but then I didn't check whether it was correct one. Anyway, it doesn't matter.
Thank you so much, ma'am. Over to you, Monica. We can begin the talk.
Thank you, and apologies for joining late. With this support and vote for Dr. Kalyan Baramde sir as a candidate for the Vice President's post in the fourth. Sir, Kalyan sir, with your permission, can we go ahead with the academic events? Let us now introduce our chairpersons, Dr. Bharti Mishra, madam. Madam is the past president of DOGS. She is a life member of FOXY, ISOPAC, IMS, IIG, PC. She's an undergraduate and a postgraduate examiner. Publications to her credit in many books. She is also the recipient of the Wonder Foxian Award and the Swayam Siddha Award. She is also given an oration at in IME Bhubaneswar. We welcome you, ma'am. The next slide, please. Our next chairperson is Dr. Sujata Kumari, madam. She is an IVF and a laparoscopic consultant at Jai Prakash Hospital at Rourkela. She is the life member of various Our next chairperson is Dr. Lopa Mudra, madam. She is the director of the Kalinga Trauma Hospital at Rourkela. She is the assistant professor at the High Tech Medical College at Rourkela. Bharti ma'am, please unmute yourself. Ma'am, you need
Hello?
to unmute. Yes,
Yeah.
ma'am. Bharti madam,
Yeah.
Bharti Mishra ma'am.
Bharti ma'am. Okay, okay.
Bharti madam, please unmute. You are the chairperson. You will need to introduce Dr. Sujata madam.
मैडम अनम्यूट करो तू.
Okay, good evening, everybody. Am I
Yeah.
audible?
Yes.
Yes, ma'am.
Yes, I'm really very, very happy to introduce my favorite speaker, and that too Sujata Kaur, and whom I refer lot of patients for my IUI, IVF and everything, because she was the second or third IVF center she has established in our Odisha. She was the pioneer for ovarian preservation in case of onco preservation and also laminar flow. So many things. She's fast in Odisha in concern to ART things. Thing is that today we are discussing optimizing IUI result. Whatever you do, you cannot give more than 20%. But patients don't understand. So before doing IUI, you have to counsel whether they are being doing with a donor or by husband, women or whatever it may, the result is little less. But they want more. So to optimize that thing, so many things have come. Sujata will be telling like when to do, how many times to do, whether scratching is required or not, GSF is required or not, what is the requirement of PRP, etc. in the IUI, and what drug is best for induction of ovulation for IUI, all these things without wasting time. We have to listen from our academician and the best in this IUI and IVF center in India, one of the best speaker also, known nationally and internationally. And so over to you, Sujata, for continuing your talk. Thank you very much for giving me a chance to chair this renowned ART specialist. Thank you very much.
Madam, thank you very much for your beautiful introduction, which you always do. I can't thank you enough. So, respected Bharti Madam, HP Patnaik Sir, Janmajay, Bhagya Lakshmi, and mostly the proprietor, the person who is responsible for these webinars is our Kalyan Barmade. Am I audible?
Yes, ma'am.
Yes,
Yes,
yes.
ma'am, you are.
Yes, ma'am.
Okay, it is getting cut off from my side. So, thank you very much, Kalyan, for involving me in these eco webinar. And you've always been an all-rounder, and you are there in every field in gynec and obstetrics. And I know you since my IAG days, but you are really active in all fields. And I'm so glad that this eco webinar you're doing and and thank you for having me here. What I did today is that I recorded my lecture because there's a lot of disturbance otherwise in the availability over phone 5G and all. And I sent it over to Monica as well as Shatabdi. I hope that throughout for and after that also if there are any question answers. So Shatabdi, could you play my
Yes, ma'am.
recording?
Yes, ma'am. I've sent it to the technical team, ma'am. They will play, ma'am. Yeah. Nitesh?
Yes, ma'am, doing it.
Yeah, yeah.
So I have chosen a topic, how to improve
Audible to everyone?
No, in between it got cut off.
success in IUI program. Now, IUI is a technique that we do every day. Every one of us practicing infertility does that every day. We also know that the success rate is, sometimes disappointing. And so we get disheartened, and even patients get disheartened with the success rate. So let us see what are some tips and tricks by which we can increase the success of pregnancy in our IUI program. We know that the success of rate of pregnancy is reported very differently in different studies, from 0 to 26%, obviously it is because of the indications of IUI that the success rate differs. But even in very good large studies, maybe about 20-year, 30-year studies which have recently been published, the success rate of IUI on an average has been reported to be just under 10%. Now, IUI success is dependent on 4 pillars. The first is patient selection. Second is perfect monitoring and timing. Third is the progressive total motile sperm count. And fourth is the IUI setup. Patient selection contraindication is more important than the indication. We have to understand that. So the best indicators in female factors are anovulatory infertility, grade 1, grade 2 endometriosis, unexplained infertility, and anatomical issues, which are rather rare, but like vaginismus and psychological issues with intercourse, etc., or a tight hymen and all that. Male factor non-obstructive azoospermia when you're doing a donor insemination, ejaculatory and sexual dysfunctions, one of the best indicators. They'll give you good pregnancy rate if the sperm counts are good. Mild to moderate oligoasthenospermia, retrograde ejaculation, and seminal volume or liquefaction defects. So, like I mentioned, choosing the correct patient is very important. We all know donor insemination programs, when the female factor is normal, have very good pregnancy rate. We know that ovulatory disorders like PCOS, if there is no other factor, no other male factor, any other factor, and if you get her to ovulate, then the pregnancy rates with IUI are excellent. And contraindications we need to choose. Sometimes questions like, if in HSG one tube is open, one tube is blocked, if there are pelvic adhesions on laparoscopy, or if there is grade 3, grade 2, grade 3 endometriosis, but the tubes are patent, we know that the chances of pregnancy are really less. Or if there are Asherman syndrome adhesions, etc. So, choosing the patient correctly is of most importance. The next is perfect monitoring and timing. We know that to pinpoint ovulation and then to plan a IUI around it is most important. Now, the perfect monitoring part, or ovulatory cycle follow-up part, again has 3 aspects: ovulation induction techniques, follicular imaging, and timing the IUI. Ovarian stimulation protocol, which one to use, is a question which many times the youngsters, those who are starting practice, ask us. That will depend on the patient profile, what is the indication of IUI, the drug cost and availability, and the patient response. For example, if a donor insemination, normal young female, I also do a natural cycle IUI. So, or if she's, just no other factor other than a male factor, then we can also do with minimal stimulation with just, oral ovulogen. But sometimes when there is unexplained infertility of longer duration, or there is grade 1, grade 2 minimal mild endometriosis, and situations like this, then sometimes we also do a combination of oral ovulogen along with gonadotrophins. We know that multifollicular ovulation, if we have more than one number of eggs, the chances of pregnancy might be slightly more with IUI, hoping that if you increase the number of eggs around the fallopian tubes, possibly the chances of pregnancy will be higher. The optimal ovarian stimulation is that we want that at least we should have 1 to 2 follicles of 18 to 19 millimeters. Estradiol we never do for an IUI cycle, and endometrium, which is more than at least more than 8 or 9 millimeters, trilaminar, and the morphology is good of the endometrium. So like I was mentioning, you can do an IUI with normal cycle, or you can do with oral ovulogen, or you can use with gonadotrophin and oral ovulogen, or very rarely one can even think about adding an antagonist in an IUI cycle. Monitoring of the ovulation, how it is done, it can be done clinically, it can be done biochemically, and it can be done sonographically. So usually for all practical purposes, we do it sonographically using a transvaginal ultrasound. We try to follow up the number and sizes of follicle, the thickness and morphologic pattern of the endometrium, and ideally it should start at least from day 7 to day 8 of the menses, if not a baseline scan at day 2. So if you have the convenience and your patient is compliant, then starting a baseline on day 2 is extremely good, but at least we should start from day 7 to day 8. Now, a lot of studies have reported the use of follicular Doppler to, study the timing of ovulation or when the follicle is ready, because we know a follicle can be ready at different sizes. So how to use follicular Doppler for deciding when a follicle is mature? So some criteria have been shown. A mature follicle shows vascularity in at least 3/4 of the circumference of the follicle. The peak systolic volume is at least 10 centimeters per second. And usually these are the criteria when the LH search starts, and this is a good time to give a HCG trigger. Rising PSV and a steady low RI suggests follicle is close to rupture. Decreasing PSV and a rising RI suggests follicle is likely to become luteinized unruptured follicle. Fertilization of a follicle with PSV less than 10 centimeters may result in an embryo with chromosomal abnormality. I do not know how much these are supported by evidence, but there is one good study that quotes these parameters. So perivascular vascularization has been quoted as grade 1, grade 2, grade 3, and grade 4. Depending on how much around the circumference of the follicle you can see blood flow. So ideal is to have grade 4, which is at least more than 50%. Now, one more thing I wanted to draw your attention to is that does follicular size and maturity differ based on ovulation induction drug? Now, when you're using a natural cycle, a follicle may be mature from any time from 18 to 30 millimeters. If you're using clomiphene citrate, it is 18 to 26 millimeters. In a gonadotrophin cycle, it is 14 to 16 millimeters. And in a GnRH analog cycle, it should be at least 17 millimeters or more. And a 3T scan can be used. These are just some of the pointers that I wanted to show, as if these facilities are there, you can more accurately point out when a mature oocyte is, when a follicle is mature. Because just giving at 18, some follicles may not be mature. So this is another possibility wherein a 3D follicular scan has been done to show the presence of cumulus in the follicle. Importance of measuring the endometrium is very important. How to monitor? We do that all the time. And we know that the endometrium can have different types of appearances. Also, sometimes imaging is poor. The endometrium is very nice, trilaminar or whatever. But if the ultrasound beam doesn't pass through the right way, sometimes endometrium is not imaged properly. If you see the uterine endometrium in a coronal section also, you will not be able to take a thickness properly. But apart from that, the endometrium can be ill-defined like this, or it can be hyperechoic, or it can be isoechoic like this. The ideal is if we see a trilaminar hypoechoic with well-defined margins of the basal layer, and which gradually increases in thickness and then slowly starts becoming echogenic starting from the base as the progesterone in the cycle starts rising. So less than 7 millimeters is unfavorable for implantation. We know that grade C, which is the best kind of endometrium, and type A or B endometrial pattern has been associated with reduced pregnancy rate. Now, the uterine artery blood flow and Doppler studies, whether that can be used to monitor endometrium, and when the endometrium is ready to be receptive, or whether it coincides with the follicular maturity or not. That is also another way in which we can try and improve the chances of success or chances of implantation with an IUI cycle. So like I said, start with day 2, day 7, day 9, peri-ovulatory, and if there is an anechoic collection in the endometrium, that we have to note, whether it is thick, whether it is thin. Chances of pregnancy is considered to be almost 0 if the PI is more than 3 in the uterine arteries and RI is less than 0.9 on the HCG day. So see, this is the uterine artery Doppler, which shows absence and diastolic volume, very, very high resistive index. And this is with minimal flow, and this with increased flow in the diastole, which is a excellent thing to happen when, as you're following it up in the ovulatory cycle. We also have more detailed uterine scoring system to predict implantation, which we usually use for the IVF cycles and not use so much in the IUI cycles at all. It is called the Applebaum's uterine scoring system. But definitely, if a patient is failing to get pregnant repeatedly, and you would want to make sure that the patient that you're dealing with has good endometrial implantation scoring, then one can use these parameters. I'm not going to go into the detail. This is a very detailed endometrial scoring pattern. Now, power Doppler of the subendometrial blood flow also has been studied, and there uterine in the endometrial cavity or endometrium has been divided into 5 zones, and then you study the blood flow pattern through all the different layers. It has been shown that if the power Doppler of subendometrial blood flow is poor around the periovular time, then the chances of pregnancy are poor and the chances of abortion are quite high. And based on the power Doppler flow, many zones have been created. Like I told you, zone 1, 2, 3, 4. If you get blood flow till zone 4, it is thought to be excellent. And in the power Doppler, automatically calculates if you have a good ultrasound machine with a 3D vocal software. We can calculate the vascularity index, flow index, and vascularization flow index of the endometrium using a power Doppler, and we have various parameters by which we can see if the endometrium is non-receptive. Endometrium volume also has been used. It has been shown that volume of the endometrium should be at least 2 millimeters. It can vary from 2 to 13 millimeters, but it should be more than 2 millimeters ml for good chances of pregnancy. So 3D or 2D ultrasound for follicular imaging, etc. This question has been asked frequently. But we know that 2D is as good as 3D or even better for us to be able to give us almost all information. So what ultrasound patterns, just to summarize what I told you till now, indicates a good receptive endometrium. Now I understand, and I'm telling you again, that these parameters usually are done for an IVF cycle. But then for a IUI cycle also, they can be utilized to see if the endometrium is good. So endometrial morphology, which is triple line in pattern, endometrial thickness, which is 8 to 14 millimeters, endometrial perfusion, which shows the presence of subendometrial and endometrial blood flow in power Doppler, high subendometrial VI, FI, and VFI on the day of HCG in the conception, chances of conception is increased. Uterine vascularity, which means the uterine artery Doppler, if the PI is between 2 to 3 and uterine artery PSV is 15 to 20 millimeters, that is ideal. Volume of the endometrium more than 2 millimeters ml is good. Persistent presence of FC waves until HCG administration is another indicator which we see during a transvaginal sonography. That means the endometrial flow pattern or mild movement that you see in the endometrium during TVS, if you note, if it is from the fundus to the cervix, it shows a good chances of pregnancy. Now, are there any chances, you must have done or heard about role of GnRH antagonist in IUI cycle. So quickly in 2 or 3 slides, I will tell you if there is any benefit of antagonist in IUI cycles. So usually it's not used. It is not of much benefit, but maybe for precise timing of IUI, it can be used. So because it controls the LH surge and times the ovulation better, proper synchronization can be done if you're doing a single IUIs. For example, if the endometrium is not ready, you feel, and the follicle is ready, then we can give a antagonist for a day or two, wait for the endometrium, and then do the IUI. And in severe PCO women with LH hypersecretion, using an antagonist for a couple of days might improve the chances of luteinized unruptured follicles and other things. Now, the second thing was timing of insemination is important. Now, it has already been shown that you can do a double or a single, but a single IUI is good enough for all practical purposes. And if you plan a single IUI, then post HCG 34 to 40 hours, anytime it can be planned. The technique of IUI is typically, I don't need to go into the details, but I like to tell this in my talks on IUI often, that we know that cervix is a very good reservoir of the sperms. So when we are doing an IUI and we push the inseminate into the uterine cavity with of 100% motile sperms, what has been shown in some studies is that it takes about 45 minutes for the sperms to travel through the endometrial cavity along these fallopian tubes and then get lost in the peritoneal cavity. So if at around that time the egg is not already there in the distal tube, the chances of fertilization reduces. So I often like to do my IUIs, and then when I withdraw, leave a little inseminate in the endocervix also, because that will lead to a sustained release of some sperms for a longer period of time. You may have heard about the automated IUI pumps that some Western countries use. I have seen a couple of those during some conferences. So it is an automated IUI pump in which around the time of ovulation, the IUI inseminate is loaded in a syringe, and then intrauterine catheter is given, and that automated syringe pump slowly, just like you give any other automated injection, this sperm sample also slowly gets released over a couple of hours into the uterine cavity. So that can be achieved naturally if you leave some sperms in the endocervix. Now, I don't know if all of you do that, or if all of you will agree with it, but this is something that is a good pointer to take back. Now, processed total motile sperms is an independent predictor of success of an IUI cycle. So semen preparation, we know that our aim is to achieve largest number of morphologically normal motile sperms in a small volume of physiological culture or culture media, which is free from debris. And like I said, this is a very, very important factor for deciding the chances of success with IUI. Our aim is to have at least 10 million total motile sperms when we are doing the insemination. Sperm, usually 1 million total insemination, 5 to 10 million is fine. If you're using morphology, it should at least 4 to 9% normal. Where sperm DNA fragmentation is concerned, we have no clear data, but we know that sperm DNA fragmentation is also an important aspect of deciding the quality of the semen that is inseminated. Now, various preparation techniques exist. Usually a sperm wash, a swim up technique is commonly used, but even density gradient is used. Most of the time, the embryologist or your technician decides based on what semen sample and how it is, the quality of the semen sample. Based on that, they decide which one to do. Evidence also shows that all parameters are almost the same, whichever technique you use. And finally, the lab setup. IUI is simple, cheap, effective, non-invasive method. It can be done almost in any setup. Many people do only IUI, and I'm sure they use a good setup. But the fact remains that it can be performed outside specialist units, but best setting is a clinic with an IVF facility, so that all the parameters can be checked.
Hello.
Best patient care can be given. So this is a very good recent review that talked about predictive factors for intrauterine insemination outcomes. I've just highlighted what are the predictive factors. Total motile sperm count more than 5 million. High sperm DNA fragmentation reduces pregnancy rate. Advancing maternal and paternal age negatively impacts pregnancy rate. Paternal obesity, maternal BMI negatively impacts IUI success rates. Letrozole and clomiphene have a similar outcome. Ovulatory dysfunction and unexplained infertility have the best outcome when you are doing an IUI. And we know that pregnancies occur in the first 3 or max 4 IUI cycles, after which they should be given up for IVF. So is there a significance of IUI now in the era of IVF and ICSI? Yes, certainly in women less than 40 years, those who have normal tubes, those who have mild or normally or maybe mildly reduced male factor, short duration of infertility, maximum do for 4 cycles. If you use gonadotropin stimulation, you will get a better success rate. So my concluding slides, 10 points to improve IUI success. Proper patient selection, sensible ovulation induction protocols, perfect monitoring for ovulation, do your own scans. The gynecologist who does their own scans for infertility management, they are blessed, because that is a very long, that takes your success rate much a notch higher. So that's important. Time your IUI perfectly. Technique, sometimes with use of vaginal misoprostol, 10 minutes bed rest, advise intercourse between 18 to 24 hours around insemination. Pay attention to disposables and what media you are using. Cultivate intelligent lab technicians, embryologists, invest in proper lab setup, and give proper luteal support. Thank you very much, dear delegates and dear friends. I hope you enjoyed yourself. Thank you very much.
Thank you, Sujata ma'am. Bharti ma'am, over to you for your concluding remarks, please. Ma'am, please unmute yourself.
Yes. Sujata, excellent talk, very informative. Just
Thank you,
I
madam.
want to know when you do a donor sperm, always it should be cryopreserved from the donor bank. What is
Yes,
your
madam. That
what
is
is your-
mandatory. That is now mandatory by law also.
I know, but so that has to be given to the house. That nobody can do this and that. They have to take the sperm from the sperm bank. Okay.
Yes.
And why the donor result is better than that of direct IUI? That you tell. From
Ma'am,
the
I don't-
husband IUI. Husband donor semen are better result than the husband. What are the points?
So donor we will use only when it is required, no? When there is azoospermia or some severe oligoacinospermia, patient cannot afford TISA or ICSI or something like that. And I think when there is a severe male factor, it is obvious that a donor is a proven fertile sample, no ma'am? So I think that is the major reason why the chances of pregnancy will be high. And mostly female factor will not be there.
Is there anything immunological reaction between husband and wife, so that they don't allow pregnancy and donor new
Madam,
sperm?
there is not much evidence for an immunological antibody. I mean, there was one time when you used to think of in that line, and even we used to think that maybe IUI is one of the ways in which we bypass the cervix and therefore bypass the immunological factors. But I don't think there's much evidence to show that. And we these days don't even do sperm antibody tests and all that. So you have a point, but I don't think we take that too much into consideration these
Okay.
days.
So what do you prefer always? Single insemination or double sometime?
Single, madam, always single.
And
Unless it is
anytime you
donor
have transferred the
insemination.
IUI, if the cervix is not negotiated or not under ultrasound guidance or anything, any other route you have done the IUI
No, I
other
have not
than
done any.
intracervical?
No. I have not
Because
had the opportunity to do
theoretically they
anything.
have told
But yes,
biomaterial.
we do. No, ma'am. I have had no opportunity to do a intramyometrial, either a embryo transfer or a IUI. Neither a gift and all, like they used to do gamete intrafallopian transfer and all those things I have not had the opportunity to do, because these days such nice hysteroscopy and all we have. If the os is simply non-negotiable, we will do a hysteroscopy and refashion the internal os and clear the adhesions and things like that. I have not had the opportunity, madam, to do
And
that.
you have
But
nicely
yes,
mentioned.
intracervical sometimes, if you do at that time you're not
Uh,
prepared, or you do not know that the in IUI is going to be so difficult, and you don't immediately have access to ultrasound guided and things like that, then intracervical may be done instead
And you
of
have told a
abandoning.
very good point that you give something in the internal os.
Yeah.
Sometimes something is also given to the posterior fornix. If
Yes.
it is a, sometimes you keep it, it may act naturally. And
Yes, because it
natural,
acts as a natural reservoir.
and
Because
nowadays
we
they are
not
telling
be
not to do abstinence. Abstinence too
abstinent.
much around
It
it.
is not good. It is not
Okay,
good.
okay,
So
okay.
whenever we are doing the IUI, that time
Hmm.
it is now shown that it takes about 40 minutes for the
Hmm.
sperm to cross through the endometrial cavity
Hmm.
into the peritoneal cavity. So
Hmm.
if we do not do exactly at the time of egg release, or
Hmm.
if it is done around the time of egg release, we know that is the best, but we can easily miss it.
Hmm. And you
So
told the use of Rilagalix in a case of antagonist tablet. For that one, is on
not
research.
tablet, ma'am. When I had prepared this, the tablet was not there.
Okay.
So I have no experience with tablet. Also, those
Hmm.
are mostly theoretical.
Hmm.
What I said about the injection antagonist.
Synchronization of the window, etc. They tell.
But I may
Ah.
have used it once or twice only to delay the IUI. Like let's
Hmm.
say nobody is available,
Hmm.
or it falls on a Sunday or a holy or something like
So
that.
from
Then
which day you start the luteal support and what you are giving? You have not
luteal
told that.
support is after. We always check the this thing, the rupture.
Hmm. So what
So
you give personally after for luteal support?
for luteal support, nowadays it is almost always oral dydrogesterone.
Give.
Hmm.
And vaginal
Earlier it used to be vaginal, but after the oral and good evidence being
Hmm.
available about the efficacy of oral,
Hmm.
I think almost all are oral now. Injectable,
Because
not for IUI.
you are one of the topmost IVF specialist of the country. So
No,
what you are
ma'am.
doing, all will follow you, even me. I will also
No,
follow you.
ma'am. No,
Thank you
hardly,
very
ma'am.
much for nice talk. And
Thank you, ma'am.
Thank you.
hope anybody is in doubt now to
Yeah.
clear. Or they will put in the
Thank
chat,
you,
we'll
Bharti
clear
ma'am.
afterwards. Yeah.
I would request Lopa Mudra madam to please give her concluding remarks.
Good evening, everybody. It is always a pleasure to listen to Sujata ma'am's talk. And as usual, it is excellent and very systematic and point wise. I just wanted to know about the luteal phase support, ma'am. When to start and when to end?
So for an IUI, normally I start after confirming rupture. And if I customize a lot also, let us say the IUI has been done really early for somebody, let's say on the 12th, 13th day, I will not add a support so soon. We'll also ask them for intercourse and all that, and I'll add it around 16th day or 17th day. But to cut a long question short, what I prefer to do is confirm a rupture. After that, add from the next day. So let's say 1 or 2 days after IUI, and usually continue for about 2 weeks. And if the patient does a serum beta HCG after 2 weeks and it comes positive, then that is continued. But for majority of cases, we don't do a serum beta HCG. So I'll continue it for about 2 weeks, 14 days after IUI, stop it. And if they don't get their period, they do a beta HCG. That is my standard practice, frankly.
Thank you, ma'am. Thank you.
Thank you, Sujata ma'am. Kalyan sir, for your concluding remarks, please.
I think Sujata Madam has given a very apt review about how to improve success rate in IUI program. It is very important to note that the new role of color Doppler for knowing the blood supply of the uterus and receptivity of the uterus is very important. Secondly, it has been mandatory to have IUI now, only donor IUI, only frozen semen sample from the sperm banks. That's very important. And one donor should be allotted to each patient. And secondly, very important, a double IUI previously was thought to have increased success rate. Even single IUI has a similar success rate. The number of IUI attempts, it has been said that 4 is a number where you can stop and go for the further IVF cycles. I thank Sujata Madam for giving her elaborate talk about how to improve success rate in IUI program. Everybody thinks that IUI doesn't give any results, but those centers where with hygiene it is done, even a proper timing of SCG, exactly doing sonography after 36 hours. These are the factors which make successful IUI. I'm really thankful to Dr. Sujata Madam from Bhubaneswar who has given her views about improving success rate. It is going to help all the practitioners to think about a modification in their IUI process and optimize the success rate. I'm really thankful to Sujata Madam.
Thank you, Kalyan. Thank you.
Thank you, Kalyan sir. We now move forward with the panel discussion on an interesting topic, that is the ART law. I request Dr. Shatabdi to please introduce. The moderators for today's panel discussion are Dr. Kalyan Baramde sir, and we are going to discuss the ART law. Our expert is Dr. Indira Palo Madam. Can we have the slide, Nitesh? The next slide, please. Is now the past president of IAGE, also the past chairperson of the Public Awareness Committee. Sir has been introduced during the inauguration, so I would skip the slide. Can I now have Dr. Indira Palo's TV, please? Dr. Indira Palo Madam is the secretary of the Behrampur OBGYN Society. She has secured the first position in MBBS as well as the graduate and final MBBS honors. She's articles to her credit and a book on immunization in pregnancy. We welcome you, ma'am. We now introduce our esteemed panelists. Please.
Hello, ma'am, you are not audible. Hello.
Am I audible now?
Yes, ma'am.
Yeah. The next slide, please. Yeah. Dr. Atripal sir is a consultant IVF specialist, the male infertility expert and fertility enhancing surgery care for fertility data. He has done his MCH reproductive medicine from CMC Vellore. Has received pre-paper presentation prizes at various conferences and including the Best Student of the Year award. He is also the editor at the ISAR Bengal newsletter, which to his international journals. We welcome you, sir. The next slide, please, Nitish. Dr. Ganeshwar Barik, sir. is a senior consultant and infertility specialist at Indira IVF at Bhubaneswar. He is also the former senior resident at MGMC Pondicherry. He has been trained in IVF and ultrasound at the Indira Fertility Academy. He holds a fellowship in fertility at the New Life Fertility and IVF Center, Chennai. We welcome you, sir. Our next panelist is Dr. Amrita Nanda, madam. She is a consultant at Birla Fertility IVF at Bhubaneswar. Our next panelist, Dr. Prasanna Kumar Nayak, sir. He has a training and fellowship in reproductive medicine at AIIMS, New Delhi. He has more than 14 years of teaching experience, including the postgraduate examiners and the guideship for PGs and fellows. He is the professor at IMS SUM Hospital, Bhubaneswar, and an associate professor at AIIMS, Raipur. Also the member of executive body of the Odisha chapter of IFS. We welcome you, sir. Dr. Sasmita Naik, madam, is a zonal clinical director and center head at Indira IVF Center, Bhubaneswar. Dr. Pragya Dash, madam, is in the 9 fertility at Ankura Hospital, Bhubaneswar. And Dr. Gayatri Satpathy is attached to Nova IVF Fertility with an experience of more than 12 years. She has achieved the Dr. Jaideep Malhotra Yuva ISAR Orator Award and the ISAR Youth Icon Award. Dr. Indira Prasad, madam, is the additional professor in the Department of OBGYN at AIIMS, Patna. She has been the assistant professor also at LHMC Delhi, and IVF in charge at the Matritva IVF. More than 50 publications to her credit. We welcome you, madam. And last but not the least, Dr. Paudami De. She is a consultant director at Matrika Women's Care and Fertility Center at Raipur and an ex-consultant at Nova IVF Center, Raipur. We welcome our esteemed panelists and we request Dr. Kalyan sir to please take over for the panel discussion.
Thank you everyone for joining for this panel. Can I share my slide, please?
Yes, sir, you can share.
But the option is not seen to me.
Sir, you are already co-host, but let me again make you co-host, so you can now share.
Just make it co-host.
Yes, I have made you. You can now share.
Still, I can't find the option. I'll just see. You need to make me co-host, please.
Sir, you are already co-host.
I don't know why I can't.
Let me do it again. Just a minute.
Yes, please.
Yes, sir. Now try, please.
I'm not getting the option today.
So, can I share on your behalf? I have the PPT. Okay, just
Yes,
allow me.
please. Can you?
Yeah, please. Just a minute.
मुझे ना सुनो यहाँ से जाएंगे
Oh, I got it. I got it, boss.
Okay, sir.
Can you see the slides now? Hello?
Yes, please. Yes.
Yes,
You
sir.
need to
Yes,
now
sir.
put on screenshot. Yes.
Okay, thank you. So we are going to talk about the ART Act and Surrogacy Act, possible litigations in the Act. So I'm thankful to Dr. Monica and Dr. Satabdi for this, all the help. Whenever a new ART Act, we think it looks to be easy to us, but we get lost in all the paperwork. We sometimes feel it's very simple. I need to have only documentation of my clinic, but inadvertently, if there is any complaint, what to do? What are the registration process? So when we go back to the history of the ART bill, September 1995 formed MARCH, that is Medically Aware and Responsible Citizen of Hyderabad, took initiative and brought to notice the NABL that unethical practices are taking place. 2004 National Guidelines for Accreditation, Supervision and Regulation came into existence and Gazette published on 25th January of 2022. ART bill status now has become law, introduced in Lok Sabha, and now it is published in Gazette from 25th January of 2022. The authorities are National Board, State Board, National Registry and Registering Authority. The National Board, within 90 days, a board shall be formed. Key powers and functions are advising the central government on ART-related policy matters, reviewing and monitoring the implementation of the bill, formulating code of conduct and standards of ART clinics and banks, and overseeing various bodies to be constituted under the bill. The state boards will coordinate enforcement of the policies and guidelines of ART as per the recommendation, policies and regulation of the national board. Registration process is board gives registration, that is PCPNDT registration is mandatory. Boards will be formed after 2022. Application of registration to be made. The registration authority or office authorized on behalf acknowledge the receipt of application for registration, and then you get the bill which is covers everything including fertility preservation. The main aims and objectives were to discipline various ART activities, to form national registry, national board, state board, and to provide registration process of level 1 clinic, level 2 clinic, and ART bank, and define their duties. Now coming to a question. A gynecologist, Dr. ABC, passed out 2 years back, wants to start an infertility practice. So Dr. Paulomi can take this. What should be the qualification and what should be the process of registration?
Good evening, everyone. Thank you for the opportunity, sir. So if a gynecologist has 2 years of practice, they can definitely practice infertility. But if they want to start, and also they can start a level 1 IUI center through the process of the National Registry Forum. But if they want to start a level 2 clinic, they should have minimum of 50 ovum pickups and should have been trained in a IVF center with a minimum of 3 years of experience. 3 years training is required. So for level 2, the one who is practicing since 2 years, passed out 2 years back, for level 2, she has to wait. But otherwise, they can start the level 1 clinic.
So level 1, there is only 2 years and she has to have some experience with someone, right?
Yes, sir.
Now, coming to my next question. This is a site where you need to register for National ART and Surrogacy portal. Now coming to Dr. Ganeshwar Barik, what is the difference in level 1 and level 2 clinic?
Hi, sir. In level 1, hello, sir.
Yes, boss.
Yes, sir. Level 1 clinic, we usually do IUI process only. In level 2, you can remove surgically retrieve gametes. You can do ICSI, you can freeze gametes. This is the level 2 process.
Okay, so anytime a level 1 consultant goes, he has to screen the patients, he has to know hormone analysis of the patient, and he can do up to IUI. But whenever he wants to do ICSI and other procedures, he has to go to a level 2 clinic. And this is a site where website registration, that is registry.artsurrogacy.government, that is a website. Now coming to Dr. Nitesh, what is the fee structure of ART registration for a new beginner? Dr. Nitesh, who is taking this question? Dr. Siddharth? Dr. Prasanta? Dr. Pragyan Dash is there? Pragyan?
Yes, sir. Good evening.
Yes.
So for a level 1 center, it's 50,000, and for a level 2, it's 2 lakhs, and it's for 5 years.
Right. And we have to renew it every 5 years. The ART bank, the fees is around 50,000. Surrogacy clinic, it is only for 3 years and 2 lakh. That is the process. Now, Dr. Sasmita Naik is there. Dr. Satabdi, Sasmita is there. Dr. Gayatri is there.
Yes, sir, I'm there.
Okay, Dr. Gayatri, what is the certificate of registration? How does it come? And what should be the rule? When should we apply?
So we have to apply it at least 3 months before. We can have 3 months in hand, and we have to apply to this register, this website which you have mentioned, sir. There we have to apply, and only once the registration certificate comes, only then we can start any of the process.
Yeah, for new centers, you have to wait till the registration comes. For old centers, You can wait for 6
And in
months.
case our registration is getting expired, so we have 5 years time. If it is getting expired 3 months prior, we have to again reapply.
Yes. And when it can get rejected? So if it is rejected because of the some deficiency, they have to specify in Form C, and we can have a chance of appeal in cases within 30 days of receiving such registration authority. Doctor, what about Dr. Gayatri? What about the owner change if you are shifting to some other place and you are giving this center to anybody else? What you are going to do?
Yes, if there is any change of that sort, then definitely we have to again do the
Yes.
the renewal also has to be. I
So
mean,
it is
the
a
re-registration has to be done for the
non-transferable.
new place. For the new place. Yes.
Yes, very rightly said. Certificate of registration shall be non-transferable. Change of ownership. Both the copies of registration shall be surrendered to the regulatory authority, and she has to apply or he has to apply fresh. And the validity of this certificate remains 5 years. Renewal has to be done 60 days before the date of expiry. So now anybody can take this staff and equipment requirement for level 1 clinic. Dr. Indira.
So can I take this?
Yes, Dr. Gayatri.
Yes. So for a level 1 ART clinic, the minimum requirement is of a gynecologist, and we require a counselor. And because it's a because it's an IUI center, so even the gynecologist can prepare the sample and can also do the IUI. So an embryologist requirement is not there as per the ART law. It is not there. So only a gynecologist and counselor is enough. And for the IUI setup, we require a centrifuge, a laminar workstation, and a microscope. So these and then ultrasound machine should be there for the IUI.
Yes. And what about my level 2, madam?
So for a level 2, the gynecologist requirements have to be fulfilled. So there has to be a 3 years work experience, or there should be a fellowship, or there should be a proper 3 years work training. So these requirements should be there. Then for the andrology procedures, there should be also an andrologist on board who can be an MS and along with an experience in andrology. Then there are also embryology requirements. So for an embryologist, there are 3-4 points which have been mentioned, that they have to be trained in clinical embryology, or they should have some appropriate work experience. Apart from that, there should be a counselor, and there is a director also for the ART level 2 center who is looking after the overall workflow of the center.
Very rightly said, madam. So mandatory staff for level 2 is gynecologist with training minimum 50 pickups, embryologist who should be minimum BSc, a junior, and MSc as a senior, a psychological counselor, medical director, and MS or DNB andrologist is must. Now coming to Dr. Paulami, can a ART level 1 clinic stimulate patient and send to level 2 for OPU?
So level 1 can stimulate only if the gynecologist working there has a level 2, meets the criteria of a level 2 doctor. If they have done 3 years of training, they can stimulate. And but we have to inform the CMHO of that particular city that you are attached, and the PNDT officer also, that we are doing the pickups in the different setup.
Very rightly said. Okay. And these are the requirements which I said. Now we'll coming to our expert, Dr. Indira madam, Indira Palu ma'am. Now coming to the question that registration process, everything about law we have talked. Can you just give inputs about your views about registration process and ART law, madam?
Actually, good evening, sir. Actually,
evening,
I am a gynecologist, and Dr. Satabdi asked me to join as an expert. Then I laughed to myself. Yeah, I am a gynecologist, but the thing that I thought that there are a galaxy of an infertility specialist there. I am here joined not only as an expert, but as a learner to listen from you. And actually, I have gone through the ART law, but whenever you discuss, then when we get much more information and much more clarity about the law. So these are the things. Actually, we have gone through the ART bill that has come out as a PDF. But when you are discussing, I'm correlating what I have read as PDF, and so I don't have an ART clinic, but I go as a I should know, all the gynecologists must know what should, everybody should know that what is the ART bill, and everybody should be aware of, even if you do or not do, but every gynecologist must know what the, our law of the nation, law of the land is telling about the ART law. Regarding this ART bill, the 3 years and 5 years and everything that has been told by our panelists, that is okay. And I have also gone through the PDF, and the way you are discussing, that is very in simple language, that is easily understandable, and will have a good take of masses from this. I'm here as a Ladna, not as
Okay,
an
ma'am.
agent.
We are discussing
Thank you,
this
Kalyan sir.
not for IVF consultant, for all gynecologists who should know what is the change in the
We
law
should know
which
this.
has taken place. What are the medical legal implication if there is some mistake done by anybody? Because sometimes you are sending a patient for surrogacy, sometimes you are stimulating and sending
doubt.
the patient for pickup. So you should be knowing what are your duties and till what level you can work in level 1, that is till IUI. You should have a centrifuge machine, binocular microscope, and refrigerator. You should have a gynecology degree. That is what is very important for this. Now coming to the
Kalyan
second
sir,
part.
another doubt is there. Can any gynecologist do a PESA test? Can it do? But there
No,
is a
no, ma'am.
confusion in the.
No, madam.
That has been there. Even if you have the
Even gynecologist who has experience can do it, but for that, government wants andrologist to do TESA-PESA.
Yes, that is the thing. That is gynecologist. Even if you have a ART2,
and even if, madam, in a
qualification.
ART level 1 center, if you do TESA-PESA, what is the role of that
No,
if you don't have
ART2.
if you
Those
don't
who
have
are
a
having
freezing facility, madam?
no, those who are ART2 facility, they can do.
Yes, if they have adequate experience of doing TESA-PESA, they can do it. But ideally, it is said that andrologist should do all the procedures on the male.
Okay.
Yes, before to act, we only used to do TESA and PESA, madam, in level 2 clinic. But after rule, now it is changed. We have to hire andrologist only, madam.
Yes, Dr. Ganeshwar, you are very right. Now coming to Dr. Ganeshwar again, what has changed for ART clinics practicing only self-gamete cycles, and how you are doing your practice now? Previously you had slight liberty, but now you are ART clinic only level 2. You don't have a cryo bank. You don't have a oocyte bank. What is the change which has happened in your practice, sir? Dr. Ganeshwar.
Yes, sir. Now mostly it is self-stimulated cycle only. Donor cycle has been drastically reduced because prior to law, you used to share the oocytes among 1 or 2 recipient, but now strictly one recipient. So now onwards, mostly we are doing self cycles.
And what are the age limits which has been? Yes, sir.
Age limit is female 21 to 50 and for male 21 to 55.
So the total should be less than 50. That is one thing. And what are the mandatory requirements for self cycle, Dr. Ganeshwar?
Mandatory requirements, there should be appropriate age, there should be proper consent, and each cycle should complete at same level of level 2 clinic only.
Yes, so age limit, legally married couple or single woman, then proper consent, proper data entry, storage of gametes and embryos not more than 10 years. And now, Dr. Paulamide, what has changed for ART clinics practicing donor cycles, madam?
The donor cycles, we need to first see the age limit. For females, it is 23 to 35. And for the sperm donor, it is 21 to 55. Also, they have to first register and come through the ART bank only. Even if it is a known donor or any family member who is donating, they have to come through the same route. And the bank, sperm bank, will do the screening, collection, and collection of the gamete, whereas the egg bank will do only the screening part. And for the egg collection, then they can supply to the level 2 clinic after screening and after proper consent and data collection.
So the change is insurance cover for complications of ovum pickup.
Yeah.
The affidavit has to be signed by the couple in front of executive magistrate or at least notary. Entry should be there. They should be allowed to donate only once in lifetime, right?
Yes, sir.
And the storage of gametes for that couple for not more than 10 years.
And it should be 7 oocytes has to be
Yes,
retrieved.
very
The
right.
extra ones can be used for the same couple. If we have to use it for like if we have to
We
use it
can't use
another
it
time,
for multiple
different
couples.
couple. We can't use it for different couple.
Direct compensation not to be given to donor can be paid indirectly by bank for transport, loss of wages and work, right?
Yes, sir.
So all money goes to the oocyte bank. From there, they will give the compensation to the donor. Yes, anybody, can a couple get a friend or relative to donate semen sample or a donor? Dr. Paulami?
I would
Yes, sir. They can get a friend or relative, but they have to get registered. The donor has to get registered in the ART bank, and all
Right.
the rules has to be followed with regards to insurance and everything.
Dr. Pragyan, you wanted to add something, doctor?
to add that this can be done in a legal way, but everything should be channelized from the ART bank only. They cannot freshly give semen sample, as we were discussing in the IUI part also. Fresh semen samples should not be used. Even if non-donor, it should be channelized to the bank, and same is applicable for oocyte donor also.
Very right. Now, coming to the last part of this ART clinic, consent for treatment, ET, AID, oocyte retrieval is must. Such consent can be withdrawn before the actual procedure. For surrogate mother, explain all known side effects and after effects such procedure, the surrogate mother concerned. Obtain in prescribed form, there are forms available. And now coming to most important part, that is ART bank. So now, Dr. Ganeshwar, you can take this. What are the functions of ART bank?
Functions is screening of oocyte, screening and supplying to level 2 clinic oocyte donors, and screening of semen sample and storing semen samples.
Dr. Indira Prasad has joined. Can you just add something, Dr. Indira Prasad?
Yeah, good evening, sir.
Good evening, madam.
ART Bank, what is the role? That's what we are discussing, right?
Right, ma'am.
So, yeah, so as we just discussed that the donors, they need to be registered. Either they are the sperm donors or the oocyte donors. So they are the proper screening, then their insurance, and all that is the work of their registration. So that is the work of the ART Bank. The semen has to be preserved also in the ART Bank. So they have to keep all the records in their registry, in their registers.
They have to keep the record and transfer to National Registry.
National Registry, yeah.
Okay.
So that is
And,
their.
yes. Anything else you want to add, Dr. Indira? And oocyte donor will donate only once in her lifetime.
Yeah, oocyte donor. Yeah, one thing more, sir. I think the donor shouldn't the donor has her own child also.
Yes, that's fine.
Is it mandatory for her to
Yes.
have her own?
At least one.
No. Now recent guidelines, single without child also they can give.
Yeah, but see, until what is my concern is whether she's pregnant, it makes a lot of big impact on the fertilization pattern to whenever you are given oocytes to the donor, right? Because she's supposed to donate only once. If her oocytes have fertilized prior and given an embryo or baby, then it makes a lot of sense to donate. So that's what is my feeling. Dr. Ganeshwar, you want to add something?
Yeah, it's a gray area right now because the ART law doesn't specify anything, and
Right.
the ICMR says that according to ICMR, the donor's baby should be at least minimum 3 years of age.
Right.
Then only we can take. So it is better we go with the ICMR because, as you said, Kalyan sir, that it is proven, her fertility will be proven if she has a baby.
Can I add, Kalyan sir? Dr. Prashant
Yes, ma'am.
here.
Yes,
Shall I join? Yeah, as Dr. Paulimi also told and Dr. Ganeshwar told, as per the law, there is no clear-cut guideline that whether an unmarried girl can give donor egg. So usually it can be given as per me because there is no article or there is nothing where it has been prohibited. So only thing is when she is married and having some children, that is good for the recipient because she is already proven fertility with her and she has a child. But even if she is not pregnant before, even if she is unmarried, she can donate her eggs. There is no prohibition for this.
Right. So there are different views, but there is a gray zone always here. And unused oocyte shall be preserved by the banks for use of the same recipient or given for research. A bank shall obtain all necessary information in respect of sperm or oocyte donor, including the name, Aadhaar number, as defined by the law. So Dr. Prashant has
And
joined.
who can start a
Can-
bank, sir? Who can be the head of the ART bank?
There are
As far as the L1, L2 clinics, we discussed that a gynecologist needs to be there and she should have some certain experience. So ART bank, I think even a non-gynecologist can open.
right. It
But
is,
are there clear eligibility qualifications mentioned in the law?
no, there are no eligibility. Dr. Prashant, you want to add something about this?
Usually the ART bank, yes, it can be run by non-medical people, but sometimes they ask to evaluate the patient before they are recruited. They need to be evaluated preliminarily about their fertility status, if they are having any disease, whether they are eligible or not. In such situations, definitely they have to attach with a gynecologist who can give them the certification that she is eligible for this. Otherwise, it can run by a non-gynecologist also.
So usually there is some level 2 clinic which is attached to these ART banks where a person will be doing the stimulation, it will be doing a pickup and all, but not at the ART bank. These processes are not done at all.
Yes, sir.
Dr.
Stimulation
Prashant,
and pickups. Yes, sir.
yes, continuation of this, can an ART bank supply egg donor to clinics located in different states, like Orissa person giving to Maharashtra?
Yeah, sir. There is no restriction on the interstate of transfer. Only thing is they have to be registered legally and all the documents and consents has to be fulfilled. And the patient, the donor has to travel to that particular ART clinic where she has to be stimulated and pickup to be done. She cannot be stimulated in other state and transferred to the pickup center.
Okay. Dr. Paulomi, can ART bank stimulate and do OPU also? Can ART bank supply stimulated donors to level 2 clinics?
So they have to they have to register and send the donor to level 2 for stimulation, because
they
it is
can't
not
do a
necessary
home pickup.
always that the ART bank is owned by a gynecologist with proper degree. So they have to, after registration, they have to send for stimulation.
Right. Dr. Prashant, you want to add something about this?
Yes, sir. She rightly told. So always the ART bank has to only to provide a unstimulated donor. The donor has to be stimulated in the clinic where it has to be the
Level 2 clinic.
Yeah.
Very rightly said. What should I do with extra gametes, Dr. Indira Prasad? I have stimulated and I got 20
Yes, sir. Initially,
embryos.
it was written that only 7 oocytes to be extracted, but then there was an amendment that we can extract all that we need. Otherwise, it can be detrimental for the woman's health. So that was a amendment that was done to the initial statement. So we have to extract all. It was just because so that we prevent ourselves from overstimulating the women right from the beginning and pushing the donors into OHSS. That was probably initially they had written 7 gametes, but if in case they themselves get overstimulated by a low dose also, but we don't have to leave those oocytes inside. So we have to pick all of them.
Dr. Ganeshwar, what you do?
We can pick all the oocytes, but we have to use only 7 oocytes. We cannot use all.
So you do ICSI for only 7.
Yes, as a level 2 clinic, we cannot store oocyte also. We can replace.
Very rightly said by Dr. Ganeshwar.
Can L2 clinic be an ART bank also, sir?
They have to have different addresses.
Okay.
Okay, an unused oocyte stored for 10 years for same recipient, then either it goes for perish or research. Commissioning parent, spouse dies, hand over to the living spouse or research. An ART bank may, for such appropriate fee as may be prescribed, store any semen obtained from donor for the exclusive use of wife or partner of that donor, records such for 10 years and then send to ICMR. The pre-implantation genetic testing shall be used to screen the human embryos for known pre-existing and inheritable or genetic diseases only. donation of an embryo after pre-implantation genetic diagnosis to an approved research laboratory for research purpose shall be done only with the approval of commissioning couple, and when the embryo suffers from pre-existing heritable and life-threatening genetic diseases, National Board may lay down such other conditions as it deems fit in the interest of pre-implanted genetic testing. So now, Dr. Paulomi, a patient comes to your clinic and she has some complaints about the procedure, that you're not done a counseling, you're not told about the charges and all. So what is the grievance cell you are made in your hospital?
So you routinely a counselor will be there and a grievance cell separately where they can counsel the patients, and time to time they can have a feedback from the patient regarding if they have any issues, so that we don't land up in trouble at the end of the procedure. Because many a times what happens, if they get a negative report, then they come back and start throwing tantrums that we have not been told that it can be negative and you have told 100% guarantee and all that. So we need a counselor, which is very important, and a grievance redressal department also. So that time to time we keep telling them the consequences and the success rates and whatever the doubts are there they have. So that at the end of the procedure, even if it is a negative report, we don't land up in any medical legal issue or a trouble.
Very rightly said. Please put a box outside your OPD in front of a visible area where grievance redressal box is there, where they can put their complaint, or you can write the name of a person who can take care of your grievances. Advertising by marketing clinic. Dr. Prashant, what is your view about advertising and marketing by ART clinics? There are so many big ads in the newspaper. Is it ethical?
Sir, usually the doctor himself or herself cannot give the advertisement in their own name, but hospital people are doing. But I don't think there is restrictions in doing normal means awareness things. But yes, any kind of advertisement where there will be directly the money or something is involved, or it is lucrating arts which is diverting or is manipulating their ideas, that should not, that is discouraged. Otherwise, doctors cannot directly means advertise their own name or their own practice.
Okay, so advertisement only for change of place, new schemes, new facilities added, or any free diagnostic camps is allowed. Secondly, they cannot advertise about the selective sex determination in any form. They cannot give false commitment of 100% success rate or money back like these schemes. So advertising is banned for such advertisement. Dr. Ganeshwar, what is your experience about this?
Yes, sir. What you told true only, and NMC also has prescribed some guidelines also. But some it's come. Ideally, a doctor should not advertise herself. Claiming
No, there is a thin line there. Doctor doesn't advertise. They're private limited company. Their hospital advertises where there is no name of the doctor. So NMC says doctor can't advertise. But
Yes,
there
sir.
is no
The
rule
company
for
can
the-
advertise, sir.
Yes, so company can do advertise.
But
So we can-
yes, about money, result, and some guarantee you should not do.
Sir,
Very-
direct solicitation from the
Also
patient is
for
also
gender
not allowed.
selection also.
Dr.
General
Amrit,
market.
you want to add something, Dr. Pragya?
Yes, sir. Yes, sir. Direct solicitation from the patient is not allowed, and there should not be any endorsement of any product, and no unethical claims or false success rate, and all those things cannot be done. But general marketing, like opening up new clinic or shift of clinic, can be done.
Okay,
Also
Dr.
for gender
Amrita
selection
Nanda
also.
has joined. Welcome, Dr. Amrita.
Thank you, sir.
What is the record keeping for level 1, level 2 clinics, madam?
We keep it for 10 years. And if there is any legal issues, then we have to keep it till the there is closure of the case. Yes.
Right. Record maintained should be minimum for 10 years, upon the expiry of which clinic shall transfer the records to a central database of national registry. That is very important. So now Dr. Paulomi is going to guide us about what are the offenses and penalties for illegal services or practices.
So for it is 10 to 25 lakhs or 5 to 10 years for sex selection. And if it is the first time they have contravened, then it is 5 to 10 lakhs. And for subsequent subsequent actions, it will be 3 to 8 years or 10 to 25 lakhs.
Very good. And whoever contracts any of the provisions of this Act, rules made therefore, which has no penalty has been provided in this Act, shall be punishable as per subsection 2 of the section 33. Right? Now coming to the no court shall take cognizance of any offence punishable under this Act, say on a complaint made by the national board or the state board or by an officer authorized by it, offences to be cognizable and bailable. But no court inferior to that of a metropolitan magistrate or judicial magistrate of the first class shall try any offence punishable under this Act. Now coming to Dr. Pragyan, what is surrogacy clinic and what are the reasons for doing a surrogacy? Dr. Pragyan, you need to unmute, please, madam. Dr. Pragyan is there? I think Dr. Indira.
Sir, can I? Yeah, sir, can I
Dr.
answer?
Prashant. Dr. Prashant, please, sir.
So, sir, to become a surrogate mother, the first, the criteria which has been changed majorly is to be an altruistic surrogate.
Very good.
Previously, it was commercial surrogacy, but nowadays the commerce part has been removed.
What is the meaning of this altruistic, Dr. Prashant?
Altruistic means she herself she is giving the consent that I will become the mother for the commissioning couple without taking any means money or any kind of other.
Yes, any
benefit.
favors, expenses, fees, or remuneration.
Yes, sir. And but they can support the pregnancy and the related costs or expenses, but directly she cannot take any kind of favor or money.
Very right. Then what are the reasons for surrogacy, Dr. Prashant? What are the indications?
Yes, sir. So there are some strict indications for surrogacy because the first and foremost thing is, first of all, that surrogate mother means the commissioning couple, the female partner should have a non-functional uterus or the uterus is absent, or she is suffering from some chronic diseases or any kind of diseases which is means affecting her health badly, so that she cannot sustain with the pregnancy. Situations like kidney failure with under dialysis and other conditions similar to that. And if she has a history of means her uterus is there, but still it is having repeated implantation failure, either due to some immunological condition or any other conditions where she has been her uterus is not getting implantation for a number of times, or the very thin endometrium cases, having a damaged uterus either due to cancer or tuberculosis leading to synechia and anything like that. And other than that, if the couple is if the couple is trying to have a pregnancy through a surrogate mother, though they should provide their gametes. Either of the couple has to provide their gametes, and we cannot take donor gametes for both of them. And thirdly, there is a age limit, as we have already been discussed, that the couple age should also be the same. The female is below 50 and the male is below 55. So all these things we have to be we have to consider before recruiting those commissioning couple to get a surrogate lady.
Very rightly said. So these are certain criteria of intending couple, which doctor has already talked. And the only certificate of essentiality, certificate of eligibility, birth affidavit has to be given by appropriate authorities, and there should be it should be done. Surrogate should be married, having her own children, not donating oocyte, only once in her lifetime. The couple shall not abandon the child. The rights of surrogate child is child born shall be entitled to all rights and privileges available to natural child. Number of human oocytes or human embryos to be implanted shall transfer one embryo in the uterus of woman during a treatment cycle. However, only in unexplainable circumstances, up to 2 to 3 embryos may be transferred. And lastly, prohibition of abortion condition will be as per the MTP Act of 2021. Now coming to the most important question to Dr. Indira Prasad, what are the offenses and penalties in surrogacy? Dr. Indira.
Yes, sir. If someone is doing sex selective surrogacy, that is, they want to give a boy child, then they will be and there's a penalty of 5 to 10 years, and they have to pay 10 to 25 lakhs. So the first for the
Anything
first
which
such
is not altruistic first. Secondly,
yeah. Secondly, it is sex selective.
right. So sex
Yeah.
selective, they have up to 5 to 10 years imprisonment, 10 to 25 lakhs, and whatever contravene any of the provisions of Act, any rules made thereafter, for which no penalty has been provided, act shall be punishable. No, the court which you have discussed. Will this act, Dr. Indira, will this act help to regain the lost confidence amongst the patient, amongst the government, or it will be bringing more transparency or more honesty? What do you feel?
Sir, actually, this act was made to protect those women who are against their will are pushed into commercial surrogacy. That is why they wanted to make it altruistic, so that without the commercial gain, whoever wants to willingly become the surrogate mother and help the intending couple, they can do. But in practicality, actually, it is very difficult to find. I mean, the couples, I am aware of many couples who are approaching me. They are not able to find such women who can actually, yes, help them with altruistic surrogacy. So, and there are so many, being in a tertiary center, yesterday only I operated on an MRKH. So, there are so many girls and women who actually need surrogacy to become mothers. So we are actually not able to maybe cater, but somehow there has to be some balance between both the things. That problem is also important when the women by their families are pushed again and again to become surrogate mothers and their health is compromised. So that, but then I don't know, somehow altruistic surrogacy, people are under the cover actually doing commercial surrogacy. Maybe they are putting on papers altruistic. That's what I would say.
We won't go into that detail. Dr. Prashant, what is your view about this?
Yes, what Dr. Indira told, that is also correct to much extent, because I am working in a fertility center. So there we are getting many couples who are actually eligible for this, but they are not getting a proper surrogate mother because being altruistic, being known to the pay couple, and they'll not charge anything. So those kind of women are very rare. Means everyone may not get that. And that's why many people are unable to get a proper surrogate mother, and they are either forced to stay back, or they are opting for adoption and all. But here, yes, if there can be some leniency or some changes in this strict guideline, that how the surrogate mother can be picked up or anything else like that, so that can help.
But Dr. Prashant, at least there were some states or some countries from where a lot of surrogacy was happening. At least they got a break on this. Commercial surrogacy is totally banned. The government was thinking about the transparency. We got that transparency. Now government, once they have control over this, they will come to these factors of not getting proper donors and all. Dr. Paulami, what is your view about has it regained the confidence among the patients, or it has become big failure? Dr. Paulamide. She's not there. Dr. Amrita or Dr. Paulami, you are there. Yeah.
So it has definitely brought some transparency, but at the same level, it has at certain point it has made few things difficult for the clinicians as well. Because there are certain gray areas, like for example, the age limit and the married or unmarried donors. There are certain gray areas which are still not clear, and taking those loopholes into consideration, there are many persons in the healthcare industry or outside the healthcare industry, like donor agents and all, who usually take advantage of these situations and repeat the multiple donors, and there are a lot of things going on behind the scene.
Dr.
Because
Gayatri
of which
Satpathy,
they are
what
in
is your
trouble.
view
Yes,
about
I
this?
would like to add one thing here, sir. Even I think it has slightly made difficult only. The difficulty has increased for the patients slightly because of the strict age limit, and also the donor cycles where we are only supposed to have only 7 oocytes So those things are also reducing the number of transfer attempts for the patients. Then thirdly, when previously we were able to do embryo donation cycles for a very cheaper cost, because that option was there where couples were able to donate the embryos
Oh, madam,
if
but what
required.
was happening? There were brothers and sisters getting married after 20 years. If you're putting the same embryos.
But now the embryo donation cycles have become so costly, and also one-time oocyte donation also, because of which there is scarcity of oocyte donors. So these things have actually made slightly our work difficult, is what I feel, sir.
No, if initially why this law came, because there were some IVF center who were doing batches and all babies were looking similar. That is the reason they came up with this law changes, and that has come for the good. I feel. Dr. Amrita, what is your view?
Yes,
And
sir.
one
It is
more
for
point
good
I
only.
forgot to
It
mention,
is
sir, regarding egg sharing also, because initially
Yes.
when we were able to do egg sharing, at that time we were also able to reduce the cost. But as you are saying, I understand because then the genetics part is getting mixed up a lot. Those things are also happening. But then the cost for the patients, at least for the poor patients, it has increased after the ART Act.
Very rightly said. Government will look into all these factors soon and can come up with some ideas if you can write to ICMR. Doctor, I
Sir,
think, yes.
what I can say is, sir, it is good for the society, but it is difficult for the ART clinicians and the clinics to perform the procedures.
So for that, this is the next slide. Swim with the tide, comply with the law of the land, and do not try any flexibility. That is what is very important. Dr. Indira Palo, madam, any
Thank you,
messages?
Kalyan sir. Yes, sir. Actually, surrogacy, many people are coming to us, general gynecology, to give a certificate so that they will not able to be a mother, so that they can go for the similar type of cases are coming to us for the certification. But we are afraid to give certification because there are so many things are there. They can be mother herself. So second thing is like surrogacy. Actually, the infertile couples, they want to get child by hook and crook. Whatever you do, so they don't understand the complicacy. What are the ART is saying, and but we as a gynecologists or ART people should have conscience that we should do so that we can give a couple of baby. So we need a change in surrogacy. Like so many embryos can get donated. So a surrogate mother can be once or twice be in her lifetime can be a surrogate mother. So in similar bills can be brought in the surrogacy bill so that we can have more women. We can get more women for this surrogate mother, because the laws would be flexible in that way so that we can get more mothers.
No, ma'am. There were a lot of problems. Dr. Bharti, ma'am, there were a lot of problems about surrogacy, and there were people who are doing uncharted surrogacy, and then there were issues of one baby not taken by the parents because of the anomaly. That's how it started, because every life counts, madam. That is what is important, Dr. Indira, ma'am. Every life counts. And that's the reason we are going to have such strict laws, because we are coming up and we have to comply with the law of the land. We can just send your reply or send your queries to the ICMR so that they can take some changes, and do not try with any flexibility. So take-home message is follow all protocols, document well and accordingly, keep trained and prescribed qualified staff, training regularly, have a system in hospital working pattern, and keep good relations with colleagues and help them when needed. So now coming to each and every panelist, one word about the new ART law, starting from Dr. Prashant.
Yes, sir. As for the new ART law, definitely it has brought transparency and confidence among the practitioners, among the patients. We should abide by the law and we should respect it, and we should also encourage others to follow the law, and the patient party, they should also be aware of it so that they cannot demand unexpected things from us. So definitely it is a good step by the government of India.
Yes,
and
Dr.
we
Prashant,
all
if
should follow.
everyone follows the rules properly, well, things will go wrong. Why we should take it emotionally and get involved into something which is going to cause your career, right?
Of course,
Dr.
sir.
Indira
Of course, sir.
Prasad, one word.
Yeah, sir, ART law with the affidavits and insurance cover has definitely brought confidence and this that even we
Oocyte
care
donors.
for the
There were some
donors and
deaths of oocyte donors where
yes,
there is a
yes.
lot of confidence now in oocyte donor because their insurance has been paid. They are being
Yes.
given travel and everything. So
I'll
that's
share one small incident when I was assistant
madam.
professor at AIIMS Delhi and on call. So there was one unmarried girl who came in shock with him abdominal distension. So on ultrasound there were bulky ovaries, but she was unconscious and she was brought by somebody who was not some family member, but she did not know why this happened and she suddenly went into shock. So when after 2 days of resuscitation and critical care management, when she came to consciousness. So she told that she had gone to, I mean, she was stimulated and gone to a IVF center. The
OHS.
pickup was done and she was sent home the same day. And the family was not aware. So
That's really good, and it is saving the lives. That is very important. One life
yeah,
saved
so
is
the
very
law has
important.
been,
Yes, Dr. Amrita
yes.
Nanda.
It is definitely good. The ART law is definitely good. It is bringing transparency and like something good to the society. But it needs to be amended in some points, like the surrogacy, as Indra Madam has said, or some like on donor sperm. It requires some safety on the doctors, because when you are taking donor sperm, we are not doing any affidavit or anything. So it needs to be amended.
So you need to do proper documentation. Dr.
Documentation.
Dr. Paulami, the
Yes,
baby
sir.
maker.
Yes, sir. So one take-home message I would like to share is always be very careful about the donor documents, because especially the insurance part, where both life insurance, because many a times in my practice also it has happened that there is only one insurance, life insurance or health insurance. So we need both, and we need to check the dates as well. Because if the insurance has been booked around 6 months back, there is a high probability that she would have given the gametes or like donated the gametes within this 6 months time. So always the date of insurance is very important, so that we are compliant with the law.
Very rightly said. Dr. Pragyan.
Yes, definitely the ART law is a very good thing, and it's also beneficial for we as a clinician, because nowadays almost everyone is speaking in the same language, and everyone is following the same rule and same law. So we are also doing more and more self cycles also. So it's also we are experimenting with many things, and also we are getting good results out of that.
Yeah, initially, Dr. Pragyan, there were problems about the low AMH patient where we were getting less results, but slowly we are picking up that part. Dr. Ganeshwar.
Yes, sir. Definitely, ART law gives us ART people recognition and responsibility. Only this punishment part gives me some palpitation.
Yes, we need to be together if there are any case. Dr. Sasmita Naik. She's there. Dr. Gayatri.
Yes, sir. The ART law has been basically introduced to keep the patient safety in the topmost priority. So
Very
let the patient also be safe with the ART law, and also we also need to keep ourselves safe by strictly abiding to the ART law till our desired the changes what we want till it has been done. At least till that time we have to strictly abide by it, so that we are also safe as clinicians.
Very rightly said, because patient safety as well as doctor safety is very important. So with this, I conclude my panel on topic of complications and ART law. What are the implications? Why law was amended, and what is the ICMR guidelines about this? And I'm really thankful to two people, Dr. Monica Umbardan and Dr. Satabdi, for helping me to arrange this webinar. And I'm thankful to Dr. Hara Patnaik sir, Dr. Janmjaya Mahapatra sir, Dr. Bhagyalakshmi Naik madam, and other chairperson, Dr. Bharti Mishra, Dr. Sujata Kumari, Dr. Lokmitra Jena, and our elder sister, Dr. Sujata Kar, who gave a beautiful lecture on optimizing IUI results. Over to Dr. Monica and Satabdi for vote of thanks.
Can we request, sir, Dr. Indira Madam to please give the concluding remarks about the panel as an expert? Dr. Indira Paloma.
Thank you, Satabdi Madam. Actually, I heard so many things. I learned so many things from Kalyan, and a clear-cut message from the Kalyan sir that we as a law-abiding person, so respect about the law, whatever the law is there. He has clearly and gave a clear-cut message. Whatever there is some confusion in the within us that this law maybe there is not in a properly drawn. But after listening to the panel views of the panelists and also Kalyan sir's remarks, I could also understand, yes, the law is good for all the people, not for the, in a country like India where everybody is not law abiding. This type of law should come, and in years to come, we can write to the ICMR whatever our difficulties are there, and within few years, the ICMR people may recommend or may do some amendment that is favorable for the patient and also the doctors. Thank you, Kalyan sir, for giving a very insightful IRT Act bill, and which will carry out in our general practice. Thank you, sir.
Yes, Dr. Monica.
I request Dr. Shatabdi to please give the vote of thanks. But before she concludes, I would request everyone to please support Dr. Kalyan sir's candidature for Vice President Foxy. Thank you, sir, for giving me and Shatabdi the opportunity to conduct this webinar, sir. And heartiest congratulations, sir, on a very successful tenure for IAG.
Thank you, ma'am.
With so many accolades to your cap, sir.
Thank you
Over
so much.
to you, Dr. Shatabdi.
And thank you, Kalyan. Thank you.
One word for me. Can you listen?
Yes, Dr. Bharti, ma'am.
Blessings, Dr. Barmuda sir.
Thank you,
And
ma'am.
such a nice things you have done today, because first one was the favorable topic of everybody, general practitioner also, and the law, what you have told and what you have discussed. Though I have unmuted myself, I was just listening everything. Discussion was very nice, and you are so academic. You must come up with Vice President next year. We must see you. Wish
Thank
you
you,
all
ma'am.
the best and my blessings.
Thank you.
Thank you, Monica, Shatabdi, and Kalyan again.
Thank you, ma'am. Dr.
Thank you, ma'am.
Satabdi.
Thank you, Kalyan sir. Hello.
Thank you, sir.
Yes, Shatabdi, you're audible now.
Thank you.
Yes.
Thank you, Kalyan sir,
Thank
for
you,
giving me
Kalyan
the
sir.
opportunity to conduct this webinar. Thank you to Hara Patnaik sir, Janmejaya sir, and Bhagyalakshmi ma'am. Thank you, Bharti ma'am. I know you were there throughout the webinar. Thank you so much for being there. Thank you,
Shatabdi,
Sujata
I
ma'am.
am
Thank you,
also.
Indira ma'am. Thank
I've
you,
been there
Lopamudra
throughout
ma'am.
the.
And thank you to all the panelists for that was a wonderful panel discussion. Thank you all. Good night, everyone.
Thank you, Team
We
Corona,
are thank
for,
you to Corona for this initiative. Thank you.
Thank you,
for the
sir. Thank you
technical
so
help
much.
and academic.
Thank you.
Thank you.
Nitesh bhai, it was nice. Thank you.
Thank you so much, sir. Thank
You
you.
update about the number of attendees soon.
Sure, sure. Thank you, sir.
Thank you, Nitesh.
Thank you,
Good night,
everyone.
everyone, and wishing
Night.
everyone a happy Ram Navami.
Happy Ram Navami to everyone.
Yeah, happy
Thank
Ramnavami
you.
and a long weekend.
Definitely, ma'am.
Thank you.